Say is that the data is, if you really peruse the data, I would say inside out is going to be shown more superiority. And if you ever rescope a lot of your high-level athletes who are putting most stress on your meniscus repair, you'll see failure of all inside always at the suture site of where you puncture the meniscus. So I think for our higher-level athletes, we're actually going back to the future, going back to more inside out, because of all the other things Sachin said. You can get more fixation, smaller holes, and you can and there's less implant breakage. So even when cost is not the issue, as if with the NFL and NBA players, I think a smaller hole is the issue. Now devices are getting smaller and smaller too. So can you put up my slides, please? Oh, sorry. So it is my slides. Okay, so I'm going to talk about some surgical pearls I do for a root repair. We've talked a lot about the anatomy of the root, but specifically we're going to talk about, I always say, the medial meniscus root and the PCL are brothers. Understanding this relationship is understanding, A, how to do a PCL, because I look at the meniscal root, and then I'm going to put my PCL relative to the root. Likewise, when I see a root damage, I look at my PCL on sagittal MRI and see this relationship of how the root goes right anterior to the PCL. So this intimate relationship is a very profound arthroscopic land point. There are various different tear patterns, but we're really focusing on the big avulsion patterns. As I said to you before, there's two types of roots. There is lateral side and medial side. We know from biomechanical data that the root is critical. The root is critical in two different ways. With the ACL, once you destabilize the root, you immediately put much more forces on your graft. So I'm very, very aggressive in fixing lateral roots with an ACL, and I'm very, very aggressive fixing any lateral meniscus tear with an ACL, because as soon as you remove a lateral meniscus, you will get some internal rotation of the knee, and you're stretching that ACL. So at all costs, you should be overly aggressive of fixing the lateral side when you're doing an ACL. Versus the medial side is a different story. How you deal with a radial tear that near the root, we used to say, oh, it was a radial tear, it's not really at the root. I now fix those and I put it in a shortened way, similar to doing a rotator cuff, where I medialize my rotator cuff. Because I think some restoration of hoop stresses is better than no hoop stresses at all. This is a paper we did when I was a fellow in Pittsburgh, and basically we showed by doing a root repair, we restored the normal biomechanics, and doing a root injury, it was analogous to removing the entire meniscus. So very profound biomechanical data that really made, to me, the concept of SPONC is gone. We don't use the word spontaneous osteonecrosis because in reality, spontaneous osteonecrosis or subchondral fractures are all related to root tears or meniscal pathology. So the meniscus fails first, there's increases forces in the medial compartment, let's just say, and if the bone can take it, you just get some what we call osteonecrosis. If the bone can't take it, you get a subchondral fracture. And it's all based on the biology of the patient, whether they can withstand that load. And we've all seen this patient. So this is something that you see very common. I can imagine a 56-year-old Indian lady walking down the stairs, going to her daughter's wedding, felt a pop, and then her knee swelled. And her MRI shows something, her x-ray shows something like this, where she's got early, maybe medial, grade 1 compartment changes, but her MRI shows this. She has subluxation of her meniscus, and here's that PCL, and here's that ghost sign, right? My dad used to always say, what came first, the arthritis or the root tear? Now it's pretty clear. The root tear happens first. And they don't always give you this traumatic story, but very commonly they do. So as I showed you before, the key to doing this operation is good exposure. You want to do a big MCL release either at the level of the epicondyle or even at the joint line. And that's Sachin was saying that even for any meniscal pathology. And then we do here that reverse notchplasty. You get into Gilchrist space, and then boom, you could see something that you never would see normally otherwise. I always say, if you look at this medial compartment right here, look how wide open that is, right? That's popping an MCL. Surgery is fun when you can see. You pop an MCL. I actually think that's actually therapeutic for that early arthritis. What do we do with a total knee? You do what to the MCL on a varus knee? You release. What do we do for an osteotomy? We release. Balancing the MCL is how we treat early medial compartment disease. So I think popping the MCL not only makes this operation 20 minutes faster and less iatrogenic damage, it gives me more fixation, but also I think it helps the natural history of the compartment. We can talk about that later. So what's my second pearl? Whether you drill this tunnel, do you drill it in 30 or 90? If you have a big notchplasty, like I showed you before, you can drill it 90, okay? You can drill it here. If it's a really tight knee and you want to pop that MCL, you drill at 30. So sometimes I drill at 30, sometimes I drill at 90, depending on the morphology of the tibial spines. Realize sharpening of the tibial spines is the first sign of early arthritis. It's like creating a PS knee. The knee is trying to get more stability because of lack of cartilage. So when you have big, sharp spines, though, it's hard to get it at 90 and you got to do it at 30. Next, how do I drill? You can use a standard ACL guide, or now every company has a root-specific guide. The root-specific guides are all fancy. Every company has one. I still like my old ACL guide best, but that's up to you. When you drill your tunnels, first looking here, medial side of the knee, I'm drilling a tunnel. The reason why root repairs work is because of this. I have a tunnel. I have bone marrow elements. I am creating a biologically friendly thing. Some people can drill sockets. I used to drill 2 tunnels. Now I just drill 1 tunnel. And I used to do a big socket. Now I just curette the bone. It hasn't affected my healing rates. But getting a nice socket with bone marrow elements is critical for this thing to heal. Then, how do I pass sutures, right? You can use all various, shoulder arthroscopic suture passers, and I do a luggage tag stitch. So I pass 1 stitch through, then loop it around, and pull it through. That's what a luggage tag looks like. Again, you need to have exposure, but when you have a luggage tag stitch, it's easy, and then you can put anywhere from 2 to 3. I showed you one example of 3 stitches into the meniscus, and it's highly durable, and it prevents pullout. So here's now, you can see 2 luggage tag stitches in here. This suture here is the suture in my tunnel, and this is my configuration. I also use a suture passer, a cannula into my knee, so I don't have any, I don't get hung up in a fat pad. And you always want to pull your sutures out so you make sure you have no conflict. And then here is the most rewarding part of the case. You're pulling your sutures through your tunnel, you're passing sutures, and you restore that meniscus. If it's a radial tear, you may not get to the root here. You may medialize it a little bit, but that's really the point. You're restoring biomechanical hoop stresses. Some hoop stresses is better than no hoop stresses. Remember that. Pearl number 5 is then suture passing in terms of tying it over a button. I use a button, or you can use an anchor to get your fixation, which you can see right here. This costs maybe $5 of a metal button. Again, when you're doing with a lateral root, you can use actually your tibial tunnel to pass the root because it's very, very close. The ACL insertion is very close to the posterior aspect of the lateral root, but ideally I try to drill an accessory tunnel if I can, but sometimes that can be hard. So in conclusion, a root tear has seen you. You need a high index of suspicion. If you fix this, you will literally save knees from getting early arthritis. And my dad would always say, the eye sees what the mind knows. Thank you very much.